Done. Go
Great.
ahead. The floor is yours, Melanie. Go ahead and put up the slides and we'll get started.
Okay, excellent. Well, it's nice to meet you, Jacinda. Let's make sure that I can get these up. And we'll go ahead and get started there we go. So I'm going to do a presentation today to cover some of the aspects, both clinical and epidemiology of adult and congenital syphilis. So I like having small audiences because I hope that there's the opportunity to ask questions. Let's go ahead and get started. I'm going to skip the first slide because it didn't format correctly, but I do want to show you, which was also in the former slide, the evolution or the emergence of syphilis over the last decade. And what we've really seen is that states, counties that never really had early acute infectious syphilis now have very high rates of syphilis. So it definitely has merged over the last 10 years and even through 2023. We are still waiting for 2024 numbers. But in 2023, I think it's important to remember that the West, I'm also located, as Brig mentioned, in Phoenix, Arizona. The West has now tied the South as having the highest rates. Now, we have seen those rates go down between 2022 and 2023, but they are still represent the highest regional rates. And we also see that among American Indian Alaska Natives, right here at the very top bar, we see generally an equal distribution or nearly equal distribution of syphilis cases among men and women or males and females. And this generally suggests my light is blinking here, a heterosexual mode of transmission versus from men to men in men who have sex with men. So this distribution is important because it does herald the very high risk of congenital syphilis, which is frequently fatal to the fetus even before delivery and also to an infant after delivery once exposed. Now, although American Indian Alaska Natives have the highest rates of congenital syphilis, they absolutely do not have the highest numbers. Now, that being either in adults or in infants. And the rates represent the numbers divided by the population size. And of course, the population size for American Indian Alaska Natives is much smaller. And you can really see that here at the top bar, where you see that although the rate is high and the highest of all race ethnicities, the actual numbers are very low. In fact, you can see that more than 10 times the number of syphilis cases are diagnosed among white people, people of Black African American heritage, and also persons of Hispanic Latino background. So this is an issue of small communities and high transmission rates. And these high transmission rates ultimately yield these very high burden areas. And the high burden areas that we see emerging are actually the ones that are in dark blue, and it can include Montana, South Dakota, of course, where I am here in Arizona and New Mexico. And a lot of these high rates, including Oklahoma, are overrepresented by persons of American Indian Alaska Native heritage. Okay, so we just take a quick look. My eyes always gravitate up to the northeastern part of Arizona, but perhaps you can see some of the areas of California that are affected. But primarily, again, American Indian Alaska Native persons are affected in New Mexico, Arizona, also South Dakota, Montana, and certain counties in North Dakota as well, and similarly in Oklahoma. So I think what we understand is that there is a lot of travel between different events that are sponsored by, supported by different American Indian communities. So we do see that the outbreak does travel across different regions of the U.S. depending on events. And now that's not specific to American Indian Alaska Natives. That's specific, but that is something associated with all cases. And we do see some travel association with that. California is pretty low. Not low, let me just rephrase that. They are higher than the US average for primary and secondary syphilis, or the US totals for primary and secondary syphilis, but they are not in the top 10, for example, for these. Syphilis is a very complex infection. And there are things you will remember and things you may forget. And so I'm glad to know that these slides are recorded. It occurs in a progression, clinically, by stage, and also by the risk and rate of transmission to a sexual partner. And what I mean by that is that there is an incubation period during which time people have the infection, but they do not have a positive test. And this period then progresses into what we frequently miss is a primary stage of infection where you have an infectious lesion at the site of exposure. Then, if you're not treated, it can progress into a secondary stage, common for a rash. And then afterwards, the symptoms can go away without treatment, and you progress into latent asymptomatic stages where your risk of transmission to someone else is very low. So these first two stages are the stages for which CDC gives the numbers because they are the most infectious, and the stages for which we like to do our public health intervention the most aggressively. At any of the stages, you can have the bacteria transmitted into the cerebral spinal fluid and into the central nervous system. And that can cause early neurosyphilis. And it can also go to the eyes and the ears and cause ocular or otic syphilis. And perhaps paramount to the negative outcomes due to syphilis are the negative birth outcomes due to congenital syphilis. And it's important to remember that the bacteria can be transmitted across the placenta at any stage of the adult infection. So when the mother is pregnant, whether that's early pregnancy or late pregnancy, whether it's primary syphilis or secondary or latent syphilis, the organism can pass across the umbilical cord to the placenta and then into the infant. So the primary stage, which I showed you, is part of the very initial phases, is characterized or heralded by a chancre. Generally, it's painless, so patients don't realize it. They don't tell their physicians, they don't notice it, or perhaps they notice it, but they hope it goes away. And then it does actually go away without treatment. But it doesn't mean the infection goes away. It just means the chancre goes away. They still remain infectious. After a while, that chancre will also leave. And then the next stage of syphilis, secondary syphilis, is heralded by these very characteristic skin lesions, but even though they're characteristic for syphilis, they can be misdiagnosed as something else. So, for example, here, the second photo shows the palmar and plantar rash. And although that's very characteristic, we do have other infectious diseases, even here in Arizona and probably in California, that cause something similar. One is rat bite fever, the other one is Rocky Mountain spotted tick disease. And sometimes hand, foot, and mouth disease can cause lesions like this. So it can be misdiagnosed, and then the patient can go on to have no treatment, and then the lesions will go away on their own. The condyloma lata frequently is misdiagnosed as genital warts, which is caused by a different organism, a virus. And then the spotty alopecia, which can occur in the beard, the eyebrows, the pubic hair, the scalp, that can be misdiagnosed as well. And then frequently mouth lesions are simply missed, but they can be misdiagnosed as aphthous ulcers. When patients don't get diagnosed or treated for primary and secondary syphilis, they progress to early latent infection. And that is an infection that was acquired less than a year ago. It can be difficult to isolate that, and that's why public health investigation, communicable disease investigation is so critical to stop community level transmission, is because we need to find patients, determine when they were infected, find their partners for that time period, and get the partners treated. But it requires that you ask certain questions because the patient no longer has symptoms, and those are related to whether the patient's ever had a positive syphilis test, and this is their first positive syphilis test, but they had a negative one a year ago. Well, that gives you an early latent diagnosis, less than 12 months. If it was their sexual debut, for example, less than 12 months ago, the first time they had sex, or if they can report symptoms consistent with syphilis within the prior 12 months. Finally, if they report having sex with someone who is known to have syphilis, this can be early syphilis. And then the basic wastebasket term for anyone else unfortunately, is late latent syphilis. And that matters because we don't have much penicillin. And unfortunately, that penicillin needs to be given in 3 separate injections for patients who have late latent syphilis. All right, so let's keep going. I do want to share that the Indian Health Service does have specific recommendations for patients who should be universally tested or universally screened for syphilis, and patients that need to be screened at more than one time point. So let's start out with the top group, or one of the priority groups, and those are patients who are pregnant. And the recommendation by the Indian Health Service is that all pregnant women be screened at the first prenatal visit, again at the beginning of the 3rd trimester, and again at the time of delivery. So what we should ask ourselves, and I remind myself each time, is that many pregnant women do not seek prenatal care. And they actually show up at the time of delivery ready to have their baby, but having not ever received the opportunity to be tested or diagnosed for syphilis. And at that point, that 3rd test at delivery is not a prevention. Rather, it is a safety net to capture both a mother and an infant who need to be treated with penicillin. Then the rest of the remaining recommendation from the Indian Health Service is now encompasses everyone ages 13 and older that should receive annual syphilis testing. And this is related to the high rates of syphilis that I just walked us through in the epidemiology slides. And there are some additional tools that can be considered. One is to turn on an annual reminder in the electronic health record. And another is to expand screening in emergency departments and urgent care settings, which is really critical to meet patients who do not have a primary care provider, pregnant women who are not attending care, and patients who have a hard time presenting for medical care during regular office or regular clinic hours, and oftentimes frequent emergency care and urgent care after hours and on the weekends. So this universal syphilis recommendation for screening is also supported by CDC. And I do have an example using Montana where we see individual counties that have high rates, and these individual places that are located in different parts of Indian country are places where it is supported and recommended by CDC that everyone should receive screening. So not just IHS, but also CDC supports universal screening. Some of the additional best practices that IHS has recommended and implemented in many service units or clinics is express STI testing. Now, STI testing, now we're going to bridge from one STI syphilis to a larger group of STIs that include chlamydia, gonorrhea, HIV, also screening for hepatitis B and C, at least hepatitis C, when there is the opportunity to have a patient come in for STI services. And when you have an express testing option, the patient basically walks in. There is no clinic appointment, there is no physical exam, but there is someone who can collect information and potentially triage a patient who may have symptoms and need to see a clinical provider, versus an asymptomatic patient who can simply give us a urine and a serum specimen and be tested for all those infections that I mentioned. And here's another list, or another way to think about that overlapping syndemic or comprehensive STI syndemic bundle. And that is to include, whenever the opportunity arises to test someone for one STI, is to test them for all, or at least all of the reportable commonly occurring STIs that include syphilis, HIV, gonorrhea, chlamydia, and also hepatitis B and C. Now, a couple things to remember is that you need to know the sexual practices for gonorrhea and chlamydia. If a patient has oral sex, rectal sex, vaginal sex, then you need a specimen collected from those sites. Another thing to remember, which sounds fairly obvious, but people don't think of it that often, is that pregnancy is a sexually transmitted condition. By definition, a woman who is pregnant, a female who is pregnant, is at risk for other sexually transmitted infections. And a patient who is male, who has a pregnant sexual partner, it's very important to consider that pregnant sexual partner at risk for other STIs as well. So pregnancy is a critical component of STI testing, both in the female patients presenting for testing, but also in the female sexual contacts of male cases. All right, the diagnosis of syphilis, this is going to be for your review record reference. And I'm going to mention one sentence about it. It is a screen and confirm algorithm, whether you do it in the traditional pattern or you do a reverse sequence algorithm. The first test is a preliminary positive test, and it is the second test that helps to rule in a confirmed diagnosis. Patients who have a positive test for syphilis may have old syphilis, and that is one reason to consider the interpretation of a treponemal positive syphilis test. It needs to be done in consideration of the fact that the patient may have been diagnosed or tested or infected with syphilis at some point in the past. If it's negative, the patient doesn't have syphilis, but if it's positive, it's important to make sure that that confirmatory test is done and that a record search through the state health department is conducted to make sure that you know whether or not the patient has been reported with syphilis in the past. It changes your management, and a patient may not need to be retreated. So this is one of the ways which I think makes syphilis a little bit complex, and that is that we do have a screening or confirmatory test, depending on the direction that your lab performs these tests, where a non-treponemal test is performed and it is reported in a titer. And if it's negative, it's negative. But if it's positive, it helps you to understand three things. One, if the patient has had a new infection because they've had a prior negative or non-reactive test. A patient who has had a prior infection who has been successfully treated will have that titer, which is usually expressed as 1 to 1, 1 to 2, 1 to 4, 1 to 8 in doubling amounts. A patient who has had a prior treatment will see that titer go down fourfold, or a patient who is newly infected who has had syphilis in the past, they can see their titer increase fourfold. So I've given you three scenarios: a new patient who's never had syphilis, a patient with syphilis who has had a successful treatment, and a patient with a prior history of syphilis who has now experienced a reinfection. So these three scenarios can occur, and this is how we use the non-treponemal titer. The non-treponemal titer can be false positive, and that's why it's important to make sure it's accompanied by a treponemal test. And that was the information on the prior slide. There are some rapid syphilis tests, and these may be one of the ones that you're using. There is the syphilis health check, which is a single syphilis test, results in 10 minutes from a finger stick. A rapid combination test that performs testing for syphilis and HIV at the same time. Very high quality, very sensitive results. 15 minutes to get those results. And then there are the home syphilis test kits called First to Know. These were just FDA approved and granted market authorization in 2004. And these are now available for patients to perform testing at home. The syphilis screening and diagnosis algorithm that is supported and recommended by the Indian Health Service calls for a first dose of penicillin at the time when a patient has a newly positive syphilis test. And then the record search can be conducted afterwards alongside a very good medical and symptom history. And this is really to recognize the challenges in getting patients to return to the clinic. We don't want them to be waiting for a confirmatory test. We don't want them to be waiting for a surveillance record search before they get that first dose of penicillin. So after an assessment for allergy is conducted, after that test result is first received, even if it's a rapid syphilis test result, we want that first injection of benzathine penicillin to be given. Now I'll review the treatment of penicillin as well. And then we do use those stages of late latent versus early latent, primary or secondary, to determine whether or not a patient needs 2 more doses. And then underlying all of this is the critical importance of contact tracing to stop community transmission that could result from an undiagnosed and untreated sexual partner. So this is a bit of a task list, and this task list is part of the IHS recommendations to take a very thorough sexual history and to connect the patient with relevant public health departments so that they can assist with contact tracing and tracing sexual partners that live out of state. As I mentioned before, we do suspect that there is a lot of transmission across state lines when it comes to syphilis in the United States. We see that patients will report frequently or having had visited a venue or a friend or a place where sexual activity took place. And then tracing the sexual contacts. The best way to find undiagnosed infection is not to screen 100,000 patients. It's rather to find the very few patients of the syphilis patient, because they will name maybe one, maybe two, maybe three, even five. But those 5 patients are much more likely to be positive than you would find in an entire population-based screening. Now, the challenge we have today, as of the Friday, I believe it was August or perhaps July the 24th, something around there, is that we have now a national shortage of penicillin, the benzathine penicillin that is used to treat syphilis. And this is a challenge because we don't have a lot of other alternatives, but the middle product is the US made product, and that is the product in shortage. The FDA has approved the importation of 2 additional products. One is from Portugal, the other one is from France. And those products are now available for purchase. And so we hope that the clinics that you work with, Jacinda, are keeping their penicillin stocked. All right, this is a slide that you'll keep for your later reference, how to manage a penicillin shortage and information that you might need as a reference, and also how to reach out to CDC to ask about that. The treatment of syphilis it's no different now than it was in the 1950s when penicillin first became commercially available. And that is that patients who have primary, secondary, early syphilis receive a single injection. Patients who have late, latent, or unknown duration receive 3 injections of benzathine penicillin. Each one is spaced by 1 week. Patients who have neurologic involvement need to be hospitalized and given IV penicillin. I've included the lenticillin ordering guidelines. If you are unable to get the Bicillin LA from Pfizer, this is how to get this lenticillin product. These are Arizona-based, but they can be used by anyone. It's no different. You're going to call the Top RX line there. And then again, to remind you, 1 dose of benzathine penicillin for patients who have primary, secondary, or early latent infection, 3 doses for patients who have late latent infection, or if you're not able to determine the duration of their infection. And these are the factors or how you determine that staging. All right, this is how you give benzathine penicillin. It's given in the hip. It's a deep muscle injection, and the X's that are marked on the hand drawing there, those are the appropriate places. So the upper outer quadrant of the hip is the appropriate place to do the injection. Now, field treatment is ideal. There are many reasons why patients can't come, won't come, don't feel comfortable coming into a clinical facility, and those can be related to pregnancy, childcare, elder care, substance use, transportation, and other privacy concerns. And so a lot of places in Indian country are having public health nurses go into the field to do these injections. And it improves the number and proportion of patients who have access to treatment and who complete treatment. We also give patients benzathine penicillin, the first injection. We give it presumptively. So we give it presumptively for 3 groups prior to having confirmation testing, laboratory testing on their infection. For example, the first group is patients who have characteristic symptoms, signs and symptoms as consistent with syphilis. We will give them an injection right there in the clinic once we do the physical exam and see those characteristic lesions. The second is if we know we have a sexual contact to a known syphilis case. We give sexual contacts treatment without waiting for any test results. And finally, when you're using rapid tests, a patient who has a rapid test for whom you've drawn a blood and you're waiting for the confirmatory test results, we do recommend giving an injection of benzathine penicillin. Ideally, you would call the state health department first to see if that patient has a prior history, but ideally you would give that first injection then. I'll leave this slide here for you just to say that very few patients are truly penicillin allergic. A lot of patients in our clinic here in Phoenix Indian Medical Center have been cared for by PIMC since they were infants, which is nice because we followed them over their childhood and now into young adulthood. But they were labeled as a child as having a penicillin allergy. And we know that penicillin allergies wane and that there is important to try and challenge them with penicillin. It is the best therapy. And then we must give all pregnant women penicillin. If they truly have an allergy, we have to desensitize them. So the desensitization process is for pregnant patients with true allergy. And then we also recognize the huge shortages of penicillin. We can treat patients who are not pregnant with doxycycline, but it is very difficult for patients to remain compliant with that drug. It causes a lot of GI upset here in Arizona and Phoenix specifically. It causes a lot of sun sensitivity, so our patients can have increased risk of sun damage during the time period that they're taking that, so it's not ideal. Really, the injection is the best way to treat and cure syphilis, so injection with benzathine penicillin. This reference is a great reference. If you think you might be interested in getting some of these little booklets, we're happy to try and connect you to a place where these can be sent to you. Inside, you'll see that there is the opportunity to challenge patients who have a penicillin allergy with a small dose of amoxicillin. The patients must first be eligible for what we call a PenFast test, and that is using a PenFast score based on their prior history of an allergic reaction and the timing of that allergic reaction. If they meet a low score, or if they have a low score, they can be challenged with a small dose of 50 milligrams. And then if there's no reaction after 30 minutes, a 500 milligram dose. And this is accompanied by close observation. Afterwards, if they've had no reaction, they can receive the full dosing of benzathine penicillin. And then the recommendations, again, there for use of doxycycline. So the next few slides are single slides covering that process, the history that needs to be collected and the scoring system for the PenFast, and then the designation by risk of whether or not a patient is likely to have true penicillin allergy and whether or not you can challenge them with an amoxicillin, or that's also an oral penicillin challenge. All right, so let's move into the later part of our presentation, and that is related to congenital syphilis. First, I want to suggest and show you the data to demonstrate the risk of congenital syphilis. The risk of congenital syphilis or syphilis in an infant is based on the syphilis prevalence and incidence in women of childbearing age. And you can see this is the distribution of the high rates of primary and secondary syphilis among women between the ages of 15 to 44 years by county. And my state here in Arizona and our border state, New Mexico, and even in California, you'll notice just how high the rates of syphilis are among women. And that rate being greater than 4.6 is the qualifier for universal screening of all women, of all patients, males and females in those areas. California for congenital syphilis, right around 13, still higher than the US total, but not in one of the highest ranking states. Congenital syphilis is frequently fatal. The fetus dies prior to delivery, resulting in stillbirth, or the infant is born alive with symptoms or catastrophic signs of congenital syphilis, or some infants can be born without clinical signs of syphilis. Regardless, this is a preventable condition. Screening pregnant women at the first prenatal visit, giving them penicillin if they're positive, or during the third trimester, are both time points for which it can be prevented. However, testing at the time of delivery is too late. Of course, at that point, we must hospitalize the infant and give that infant IV penicillin. So some of the more important things to remember as we're wrapping up is really the case management component of adult and congenital syphilis. We're trying to stop transmission at the community level through sexual transmission, and we're trying to stop vertical transmission from mother to child. So this requires close communication and true collaboration with your state, county, tribal health departments, also your tribes, also the Indian Health Service, so that you can prioritize data sharing, case investigation, and contact tracing to stop community level transmission. And then this case investigation contact tracing is something that you might want to check into really just to understand whether or not it's being done for American Indian Alaska Native patients in California, because it is the critical link to find undiagnosed infection and also ensure your patient is adequately treated. And finally, it's important for us to recognize that we do have some logistical barriers that are challenging the care delivery for patients who are at risk or infected with sexually transmitted diseases in general. One, particularly for congenital syphilis, is the limits, very dire limits in the number of OB providers in Indian country, particularly in the rural counties in the United States, in the Dakotas and Plains areas. And then there's also some real challenges with data sharing that can be prohibitive in involving tribal health departments in the activities related to public health investigation that are affecting their communities and where state health departments oftentimes don't reach. And then we do want to recognize this, the really highly influential exposure of substance use disorder among women who are pregnant, and having that influence their risk of obtaining prenatal care and their risk of having syphilis and congenital syphilis in their infant. There are some things that we can do. Patients' incentives is one of them. We know that we've had some success for TB and medication-assisted therapy for addiction, also diabetes, and we also know that this has worked really well to improve screening for syphilis. And then finally, there have been wonderful educational, community-based educational resources developed by the Northwest Portland Area Indian Health Board, the Intertribal Council of Arizona shown here, and if those are of any interest to you, can be distributed in communities for which you're serving, I encourage you to reach out to us and we can help get those to you. This is my last slide, and I look forward to answering any questions and to getting feedback from you either in person or by email at a later time.
All right, so we can stop the recording.